Hi, this is Alyssa, Critical Care Pharmacy resident, and my clinical pearl today will cover vancomycin monitoring and the transition from trough-only monitoring to monitoring of the AUC, or area under the curve. Briefly, vancomycin is a glycopeptide antibiotic, and it's been FDA approved now for more than 5 decades. Vancomycin is used mainly for broad-spectrum gram-positive coverage, especially of more resistant microorganisms, such as methicillin-resistant Staph aureus. The main side effect I want to pull out is nephrotoxicity, and this generally occurs when vancomycin is used at higher doses. So when we target a trough of 15 to 20, when vancomycin is used for a long period of time, or when a patient is also receiving other nephrotoxic medications, such as piperacillin tazobactam. You're all familiar with vancomycin trough-only monitoring, as this is really what we've done in recent years. Target a trough anywhere from 10 to 20, but typically 15 to 20 when we're using vanco for more severe infections. We wait until steady state to check the trough, so before the 3rd to 5th dose, and then based on that, we adjust our dose accordingly. And this really represents where practice will be changing, as we will have new guidelines released shortly that will recommend switching from trough monitoring to monitoring of the area under the curve to minimum inhibitory concentration ratio. So taking a bigger look at what this exactly means, we know that antibiotics in general each have a pharmacodynamic parameter that predicts their effectiveness. So for some antibiotics, like our aminoglycosides and our quinolones, we want to target a high peak. On the other hand, for our beta-lactams, we want to keep the concentration above the MIC for as long as we can. And that provides the justification for why we give Zosyn as an extended infusion. Vancomycin, on the other hand, doesn't really quite fit either of these. It's going to be AUC above MIC dependent, meaning that really we're looking at overall exposure to vancomycin. We're shooting for an AUC above MIC of 400 to 600, and this is over a 24-hour period. Briefly want to touch on a couple of assumptions that we make with the AUC to MIC monitoring. And the first is that this is really specifically being used for Staph aureus, so it doesn't really apply to other types of bacteria. The second is that we're assuming that the minimum inhibitory concentration of the Staph species is 1 to vancomycin. In most cases, that's going to be true, but just kind of keep in the back of your mind that there can be cases where the MIC creeps up. So if we see a higher MIC of 2, indicating more vancomycin resistance, as you can imagine, it's going to be a lot harder to achieve an adequate AUC above MIC ratio. So key point to know in those cases is that typically we'll end up switching patients to an alternative like linezolid or daptomycin once we see that susceptibility and an MIC of 2 to vanco. Now, how are we actually going to carry out the AUC monitoring? There are a couple of different ways. The one that I want to focus on for the purpose of this clinical pearl is peak and trough concentrations, because this is primarily what we'll be using. We can check a peak 1 to 2 hours following the end of our vanco infusion, and then we'll continue trough monitoring, and this will allow us to extrapolate the area under the curve. Again, we want 400 to 600, and we don't want to push the AUC too high because that increases our risk of causing acute kidney injury. Just like trough monitoring, this will be done at steady state. We can either do it within a dosing interval or for practicality, more often than not, we're doing this around 1 dose since we don't have to wait as long between levels. So in summary, practice will be changing from trough-only monitoring to monitoring of both the peak and the trough with vancomycin. And this will allow for estimation of the area under the curve, which we know is a better predictor of vancomycin effectiveness and toxicity as well. And then kind of the kicker here is that we're finding that those lower trough values of 10 to 15 actually tend to produce an AUC within our goal range. So when we targeted those higher troughs of 15 to 20 in recent years, we were probably exposing patients to more vanco than they needed and predisposing them to more acute kidney injury as a result. And that summarizes my first clinical pearl. Please reach out to me if you have any questions, and thanks for listening.